It should be the same. If we looked at what we were doing, what we should be doing, and asked the same questions probably 6 months or more ago, we all would have given the same answer and expected the same equipment. But this has been a whole new experience, and I think everybody's beginning to understand that now. The pandemic is not like anything that we experienced before. It's a new virus, a novel coronavirus. Nobody has any immunization for it. There's no vaccine for it. And it's spreading very, very quickly. Fortunately, it's not overwhelming for most people. They'll get through it without a big deal, but clearly for those people that are susceptible due to chronic illnesses like lung diseases, immunosuppressive issues, asthma, a variety of things, they're predisposed to a more difficult time to get over this illness. And so for them, we're trying to protect them. And so we wish we had the protective gear that we really should have. And by that I mean, if you go into a room and a patient has coronavirus, you would obviously want to make sure that you are protecting yourself, and you would generally wear an N95 mask. And an N95 mask is essentially a mask that will screen or filter viruses. It's called 95 because it filters 95% of the particulates coming through to a 0.3 micron. The virus is actually slightly smaller than that at 0.12, I believe. But still, as it's explained, because of the amount of virus coming through at one time, it still acts as a very good filter against the virus. A regular surgical mask that you normally see, or just a regular mask that you would see, you would wear for any number of cases, mostly actually to prevent the individual who has an issue is trying to stop the droplets from going to someone else. Right? Or you could use it to stop droplets coming to you, large droplets. But the mask is loose and it allows air in around it. And obviously, if you don't have the rest of yourself covered, then you're certainly exposed as well. So surgical masks, while they're helpful, they're not as appropriate as an N95 mask in preventing somebody from acquiring the virus because it can slip in behind the mask or potentially come through it. So N95s really are the mask of choice for anybody that's COVID positive. Now, the issue that we face today is because there was so much commingling of the patients inside the hospitals, and we weren't able to get them triaged out of the regular floors but on their own floors, and we don't really have testing readily available. So it's not like I can just say, gee, I wonder if they're positive because they're slightly symptomatic or whatever, and I give a test and I know right away whether or not they are or not. We don't have that. So I don't know, and even in the case of COVID, where you're not symptomatic, what we have found is that symptoms may not show up for after 5 days, and yet the virus is highly contagious during the first 5 days when you're not symptomatic. And all of that comes down to the rationale, as we've put out, that you have to take a precautionary approach, which means essentially you have to look at it that every single patient in the hospital is potentially COVID positive. And so therefore our position has been that everyone entering the room providing direct care to any patient at this point, and certainly the ones that are definitively COVID positive, should be wearing an N95 mask and a face shield. And that's really the standard that we're pushing forward. And that anybody not in the patient care room should wear a surgical mask. That's in many ways important actually just because I don't know if I was COVID positive. And so therefore if I put on a mask, I can protect myself from giving it to somebody else and also in some way protect myself against somebody that may sneeze or whatever inadvertently. It's not a great protection, but it's something. And so everybody outside the patient care area should wear a surgical mask as well. That would really be the best standard right now, and that's the one that we're trying to apply. The problem is supply. When you take a pandemic and you affect the countries where these products are coming out of, which is mostly Asia, a lot of it coming out of China, and all of these countries are also faced with the pandemic. They have companies and factories shut down as a result of the pandemic. The supply chain that would have normally been in place is really disrupted. So everybody is running around trying to get the same thing at the same time across the globe. And that makes for the problem that we have today. So the short answer is yes, we should all be getting the same equipment. The answer right now is it's not happening because nobody can get their hands on the right equipment. And so the CDC, and really what will be a sad moment, I think, in our history, the CDC has actually put out a lowering of the standards, saying that, well, if you don't have these things, then, try this. Down to the point of actually saying if you run out of everything, use a handkerchief. I mean, who would have thought that that's the type of recommendation that we would get from the Centers of Disease Control prior to the pandemic even really hitting the United States of America. So yeah, so we should be using it. We should all be getting the same thing. The problem is the supply is not there, and now rather than see an approval to lower the standards, our viewpoint is no. We need to try to do everything we can to find supply chains in order to keep the standard up. If we don't do that, here's the big risk. If we don't have folks going into the patient care rooms with these N95s and really protecting themselves at an appropriate standard, then what's going to happen is healthcare workers are going to become exposed, and either they're going to want to quarantine them, which is never going to be able to fly in the next couple of weeks, or they're going to get sick and they're not going to be able to work. And we're going to see a large percentage of the healthcare workforce not able to provide the care just at a time that the surge is going to be coming. So probably in the next week and a half to 2 weeks, the surge is really going to be on us here in Massachusetts. And if all of our healthcare workers become sick, where are we going to be then? So now's not the time to lower the standard. Now the time is really to enforce the standard and find a way to accomplish that successfully. We've heard this question from people saying that, you know, they might have their own N95 mask when the manager or somebody is not able to give them the equipment that normally we would say would be appropriate. Our answer is unequivocally, wear it, all right? And you have the full backing of the M&A in doing so, because, you know, the mentality at this point, the idea that somehow, well, that will be unfair to other people who don't also have one. You know, I don't mean to be rude about it, and I understand that, and I would love to, we will continue to work as hard as we can on getting as much supply even we can get, even though it's not really our job to be doing this, but I think all hands on deck. If we have supply, we'll be distributing it as much as we can. But if I'm a nurse or a healthcare provider and I'm going to put myself in harm's way during this virus, and I have the ability to protect myself, I think you should absolutely do that, because if you don't and you get it, we lose you. If you go down sick and now you're out for 2+ weeks, that's not going to do anybody any good. So I would ask the question first. If your manager comes up to you and says you can't wear that, then you should ask the manager flat out, what are you going to do if I do wear this? And if they say, I'm going to discipline you, what? What form of discipline would you give me? Ask specifically what the answers to these questions are. Ultimately, you have to make the personal choice, but frankly, in the midst of a pandemic, are we actually going to, fire people because they actually bring protective equipment that the employer themselves cannot adequately provide? That's ludicrous. So no wonder we've been seeing employers back down. It's you know, I understand fully, and I know your family members are frightened too, and they want to make sure that you, when you go to work, are adequately protected. So wear it, and do so with our backing, and we will continue to try to get as much supply out there as we can too, so that everybody can be as protected as possible, and we can all stay as much in the workforce as we can as this continues to roll out over the coming month. It is true. For the very reasons I just laid out earlier, is that these are unusual times. Is it absolutely the obligation of the employer to provide you a safe workplace to work in? Yeah, the answer is unequivocally yes. And here we are, with the employers unable to actually provide the standard of care that we believe should be in place that's in the best interest of both the workforce and the patients. So we have choices here, and one of our choices is to sit and just say, oh well, that's not going to fly with the Mass Nurses Association, and certainly not going to fly with the members. You know, if you want something done, ask a nurse could do it, right? And so I saw a lot of nurses immediately recognize that there was something suspect here and that things were not going to go the way that they thought. They went to ground immediately and started calling manufacturers, asking for help, putting it on Facebook. The Brigham and Women's nurses did it immediately. They're a large unit, and they started getting donations and contacts from people. So we set up in the organization with our nursing division and a health and safety division a mechanism by which anyone that has a manufacturer or a contact that is willing to work with us to give us that name. We'll vet the manufacturer, because there's a lot of scamming going on and there's a lot of issues with pricing and whether or not really surprise shows up at this point. But we'll vet them through that the product is appropriate, that it's FDA approved, that the pricing isn't a scam, and that the supply chain is good. And if it is, the organization has already put forth an order of 20,000 N95s. We will see whether or not those will be delivered. As I said, there's a lot of problem with even Homeland Security at this point has taken some supplies that have arrived and moved it to the federal government instead. And I don't know what that does, because the federal government doesn't seem to be supplying the states at this point, so we're not quite sure where that goes. So we want to make sure the supply does get to us. If it does get to us, we will again make another order of a bigger amount, and we will give those in distribution to the nurses out in the field. The board is also looking at whether or not to, because we've had people contact us saying, we want to make sure the nurses get this. And these are people that no doubt have been in the institution, went through a life-changing event. The nurses help them through that, and they see what's going on, and they want to help in any way they can. So we had one anonymous donor, who wants to remain anonymous anyways, provide us with $100,000 for us to match to try to get N95 masks to the nurses' hands. So we're in the process of doing that, and we're in the process of setting up a link site for other folks that may want to do that, in which we'll try to match with whatever we can, and we'll try to find honest, quality manufacturers with guaranteed shipments, so that we can get them and distribute them out into the hospitals. And if we can expand it beyond the M&A, we're certainly going to look at do that. I think the employers are nervous about it because it's not coming from within, but I would say this much: look at, if we can get a high standard of care in, and we can reduce the likelihood of workforce going down with this illness while we're desperately needed at the bedside, then I think the right answer right now is thank you. It's a good question, and we've been on this now for about a week and a half or 2 weeks. Seems like time goes by. I think maybe it was a week ago, we had been raising the issue in our recommendation letter to the governor at that time, that everything that we had seen from our European counterparts, which were on the phone to a variety of people trying to get a lay of the land, as one physician put it to me, I thought it was aptly said, the United States of America is being given an open book test and it's failing. So we have to look to who's been ahead of us in this and get their recommendations and understand what's in front of us. So understanding what's in front of us is, they're saying essentially, when the surge hits, what do we need for capacity? Well, when people really do need to be vented, it's probably going to be 3 weeks before a person potentially gets off a vent. That's not a guarantee. Some people may get off earlier, some people may get sick and have respiratory issues but not be vented. But I'm saying the population that really gets sick, that does need ventilator support, it's not going to be a quick turnaround of 4 days or something where they just need support and then they go off. It's a longer period of time to get them through it. So we had already asked that they be identifying additional space for ICU beds and redeploying staff, that as a result of the elective surgeries and procedures being discontinued, that those staff be redeployed and trained where they are able to help with the ICU and increase critical care bed needs. If it's any indication, we may need double to triple the number of ICU beds that we have in order to accommodate what we expect to happen. For the ventilators, because we're really concerned that the supply, as every single state in the nation will be looking at ventilators at the same time, never mind every country in the world doing the same, that's a huge problem on the supply of ventilators. So we had put up a video of a physician that had worked during the Las Vegas shooting, in which there was a sudden influx of people who had been injured by bullet wounds in the lung and thoracic area and needed ventilators quickly, and the emergency departments were overwhelmed. They could get them in the cities, but they couldn't get them immediately, and they had to make very quick decisions that could be life and death decisions for those individuals. So they did ask the families, as they quickly figured out there was possibly a way of putting more than one patient on a single vent, and had said to the families, you have a choice here. We can make a decision about who gets the vent, or we could try this. And the families went for it, and they found a way to sustain folks on the ventilators, a ventilator with more than one patient, in order to get them through. So we had put up the video because we felt like if you can't get ventilators, then you need to think out of the box. And if this is a reasonable solution, we should start thinking about it now, how to accomplish it, how to set them up in a room, and how to train people to do it. So I think the answer is that, identifying in all of the hospitals where the additional critical care beds can be so we don't run out of them, and redeploying and retraining staff to assist there, and then also the ventilator support, looking at how to be able to put more than one patient on a vent if we need to, and how to do that now and make sure we have the supplies needed, the extra tubing and whatnot, to be able to accomplish that goal. I understand, and that's a really good question, and we've heard from a lot of nurses as well as other healthcare folks saying the same thing that are going into the rooms. And I do think in the rooms themselves, we really need to be cognizant of the fact they need to work incredibly smart in this situation. So like, In the ICUs, we've already said to them, there's very little protective equipment, so you're better off having a runner nurse assigned in the ICU and allowing the nurse to be one-to-one with a patient in a room, so they don't have to keep taking the equipment on and off when there's really no equipment to replace it with. So we have to be smart about how we do the work there. We also have to be smart then about when we go home and how we treat ourselves. There are two things in this. One is, if you've got somebody at home that's at risk, however that might be, then I think you need to identify that, right, to your union, to your manager, and identify that that's a problem. We are actively working with the hospitals and with the legislators to identify hotels and dorm space in the areas of the hospitals, so that if you really feel that going home would really put somebody in unnecessary harm's way in your family, that maybe what we can do is have you stay at the dorm or at the hotel, and so that you're not putting your family at risk, but still then allowing you to do what you need to do as a registered nurse or a healthcare provider because you're so desperately needed right now. If that's not readily available, or for some reason that's not going to work for you, I think the nurses have been really smart about this. A lot of them, what they're doing is trying to designate, particularly if you have more than one bathroom in the house, that when you get home, first of all, you do not wear your shoes home. I don't care what you have to do, but find a place either in the institution or leave them in the trunk of your car, or do whatever you have to do, but bring a separate set and switch them out. As far as your scrubs, we've been pushing the employers, leave them there and let them laundry there. You should not be wearing them home if at all possible. If for some reason you are having to wear this stuff home, once you get home, you actually have to take those clothes off. They have to be laundry that night, right? The virus doesn't last longer than 4 hours from what we can see on clothing. So if you take them off in the house and you launder them that night and take a shower, we think that is a good practice, and keep that segregated where you do that from the rest of the household, period. So that you're doing extra safety measures to make sure that you're not shedding the virus potentially, if you're unknown carrying it, back into the household. I think it's a great question, and I wish I had the perfect answer. I don't think any of us know right now. We're watching closely what's going on in China, since China was the beginning of it all, where they had the first outbreak. They functioned differently and could function differently than we could as far as the way they locked down Wuhan, the city that first had the outbreak. They shut down the whole city. You didn't move outside, and that really was able to contain it much better. We don't have that luxury here. And time has already passed us for that anyways. People have moved across, cities and towns and states, and, moved in and out of countries by the time really there was an awareness. So the virus is already among us. And I don't think until we have really rapid testing are we going to be able to have a better sense of exactly how long this is going to go on. Because if we had rapid testing where any individual could test themselves and immediately know yes or no, we would then know exactly where the virus is clustered, and then we could have a strategic plan to go after it right there, and you could target your planning of quarantine and whatever. When you don't know, just like as I'm saying in the hospital, if you don't know if the patient is or isn't COVID positive, you got to treat them like they are. So we have to treat the whole country like they're COVID positive right now, or at risk to be COVID positive, until we get better tested, rapid testing. And certainly the testing for the healthcare workers needs to be first and foremost, because we don't know that. We don't want to be giving it to patients, but we don't even know if we are ourselves. And then as we look across other countries, we do know that the locking down, the quarantining, and the really reducing any social networking is making a difference. It's not in the end going to make a difference of whether or not the virus spreads throughout. It will, but it will make a difference on how fast and how many people get it at once, and that's going to make the difference on the survival rate, because if we can get people through it, the ones that are hard hit, because they're not all coming in at the exact same week, we got a better shot here. So far, from what we know, we are at least looking at going through June here. And I think that at this point, for the peak for Massachusetts, I'm talking to my colleagues in New York right now, and they're right up to their eyeballs in it in New York City. And so I think they're hitting their surge now in this next coming week, this week and next week. We can expect, given where we are near New York and how this virus is, escalating here, that probably our surge is going to be, from everything I've reading so far, is probably about a week and a half to 2 weeks here in the Boston area in Massachusetts. That'll be when the bulk of the patients are coming through. And that's going to, that that's not going to be like a surge of a day and then it disappears. It's going to be the surge will be honest, will be full, there'll be a lot of work, and then it'll probably continue on 2 to 3 weeks from there as it begins to then go down and de-escalate the numbers that arrive. You're looking for when the number of cases aren't going up anymore, they're plateauing, and then they're starting to go down. And I think in all honesty to people, we're probably looking at June. And we have asked the governor at this point, the stay-at-home order, which, you know, we would love it to be a little bit more stricter than that, but nonetheless, whatever the order is, the schools, the social contact and whatever, definitely needs to be extended out, because right now I think it's technically only extended through April 7th. And that is like when the surge is going to hit us. So it needs to go longer than that for sure. I know that's hard for people to hear, but I do think it's working. What we're seeing in other countries is those that are really judicious about doing this is having a positive effect. And as I have said before, I think the public should look at themselves as the extension of the workforce right now in healthcare. What you choose to do right now as an extended healthcare worker by not doing a lot of social interacting is quite literally making the difference on the number of people that will survive this or not. So I know it's kind of an unusual and it's a hardship and whatnot, but I think if we can do it, all the better for the patients, and we'll get through the other side of it, and it's going to cause, you know, us to, I think, be extremely creative about how we are able to socially interact with people. But I do think we're probably looking to June, and that's just based on what I'm reading so far.